Our next section is AIDS. Well, we have primary immunodeficiency diseases like common variable immunodeficiency or Bruton's X-linked agammaglobulinemia. Now, acquired means that the acquired immunodeficiency from an infection. Now, HIV, the biggest issue about HIV is actually what are the prophylactic medications and what are the adverse effects of drugs and what do you do about pregnant women? Now, there's very little asked about HIV on the test. The amount that you have to know is very small. I don't think you're ever going to be asked questions like what is the difference in efficacy between the different regimens. There's 20 approved medications just for antiretrovirals now, and you could pretty much say that the different indications has pretty much evolved beyond what you need to know for step 2. However, you do need to know when to give prophylactic medications, and you need to know what are the adverse effects of the medications that when the specialist starts those medications, that you could recognize the adverse effects of medications that your specialist has started. For instance, if you have a person who's got less than 200 T cells, we have pneumocystis prophylaxis. Pneumocystis prophylaxis starts at less than 200 T cells. The best initial pneumocystis prophylaxis is Bactrim or trimethoprim sulfamethoxazole. The problem is like all sulfa drugs, has a high frequency of rash. 10% of the population is sulfa allergic. So what will you use if the person is allergic to sulfa medications? And the answer is that you can go either to dapsone or you can go to atovaquone. Dapsone or atovaquone. Now, aerosol pentamidine is a drug of virtually no use anymore. Because if you are under 200 T cells, we would use Bactrim and dapsone or atovaquone alternatively. Now, if you have glucose 6-phosphate dehydrogenase deficiency, we don't use dapsone. However, then you use atovaquone. Now, atovaquone is a drug that a number of you are not going to have heard of because it has very few indications. In other words, atovaquone is a new antiprotozoal drug. It has very few indications. Atovaquone's indications fundamentally are malaria prophylaxis, atovaquone proguanil, malaria prophylaxis, and pneumocystis. But malaria and pneumocystis, and that's about it. However, it means that the indications for aerosol pentamidine are essentially zero, because you never get down there. The development of antiretrovirals in the last 12 years has been so extensive that the percentage of the population under 200 T cells is 90% less than it used to be. So if you take that tiny percentage that's under 200 T cells, and then say the ones that are allergic to Bactrim, and then of the ones allergic to Bactrim, they can't tolerate dapsone and atovaquone, aerosol pentamidine has the least efficacy and the most adverse effects. Now, the only other routine prophylactic medication is at under 50 T cells is for Mycobacterium avium intracellulare, also known as Mycobacterium avium complex. MAI and MAC, Mycobacterium avium intracellulare, Mycobacterium avium complex. This is the only other routine prophylactic medication. Azithromycin is the routine prophylactic medication. It's once a week and it's very easy. That's it. What will the wrong answers be for prophylaxis? Herpes. No routine herpes prophylaxis. Herpes, giving routine herpes and giving a routine acyclovir, that is wrong. CMV, giving routine ganciclovir prophylaxis, that is wrong. There is no routine prophylaxis for herpes or for CMV. Remember, prophylaxis means that you never had the disease and we give you acyclovir or ganciclovir to prevent it. Prophylaxis. If you have less than 200 T cells, you never had pneumocystis, you should be on Bactrim, for sure. You have under 50 T cells, you should be on azithromycin, for sure, but not for acyclovir and not for ganciclovir. There's only 2 routine prophylactic medications. And toxoplasmosis? Well, Bactrim is toxoprophylaxis. Bactrim is the toxoplasmosis prophylaxis. So you're already on it. You are already on it. Now, prophylaxing a person who has a positive PPD, we give INH for 9 months for anybody whose PPD is greater than 5 millimeters at any T cell count. That does not have anything to do with T cell count. That's giving INH for 9 months to anybody who's got a greater than 5 millimeter PPD and is HIV positive. 5 millimeter PPD, HIV positive, any T cell count, you get to eat 9 months of INH. Now, everybody who has HIV should get the flu vaccine and pneumococcal vaccine. Pneumococcal vaccine and the flu vaccine is routine for everybody who has HIV. Also, these are at any T cell count. Now, the questions for HIV medications will most likely be to ask you, hey guy, do you know which drugs which give which adverse effects? Hey guy, do you know that if the question says, a man comes to the office, he has been placed on 5 HIV medications of various kinds. He comes to see you because 2 weeks after starting the HIV medications, he has developed a rash. What is most likely to have caused it? Which of the following will you stop? What is most likely to have caused it? Which of the following will you stop? So you say, well, the guy has a rash. What's most likely to have caused it? Which of the following will you stop? A guy comes to see you 2 weeks after having been put on antiretrovirals. He has developed himself anemia. Which of the following is most likely to have caused it? Which of the following will you stop? He's developed himself a pancreatitis or a peripheral neuropathy. Which is the most likely to have caused it? Which of the following will you stop? Which is most likely to have caused it? Which of the following will you stop? A guy comes to see you because he's been started on 5 HIV medications, and he's developed a kidney stone. Which of the following is most likely to have caused it? Which of the following will you stop? What's most likely to have caused it? Which of the following will you stop? Well, this is the very basis of what the most likely HIV questions are. A guy goes on 5 HIV medications. He has developed anemia. What's most likely to have caused it? What's most likely to be stopped? Zidovudine. You see, they want you to know that this is the wrong time to stop the protease inhibitors. Protease inhibitors don't cause anemia. Ritonavir does not cause anemia. Saquinavir does not cause anemia. Indinavir, Nelfinavir does not cause anemia. Amprenavir, Atazanavir does not cause anemia. They want you to know that it's time to stop the zidovudine if you have anemia, not to stop the wrong med. The same way protease inhibitors cause hyperglycemia and hyperlipidemia, and we don't want you to stop the zidovudine. We don't want you to stop the zidovudine if you have developed hyperlipidemia and hyperglycemia. A guy comes to see you 2 weeks after having been started on 5 HIV medications. He develops peripheral neuropathy, numbness and tingling. What will you stop? What's most likely to have caused it? These things are caused by stavudine and didanosine. What's most likely to have caused it? Which of the following will you stop? A man comes 2 weeks after starting 5 HIV medications. He's developed flank pain and hematuria. Flank pain and hematuria. What's most likely to have caused it? Which of the following will you stop? What's most likely to have caused it? Which of the following will you stop? And the answer is indinavir. Only indinavir causes stones. The boards will want you to know not to stop stavudine and didanosine for kidney stones. On the other hand, they don't want you to stop indinavir for peripheral neuropathy and pancreatitis. On the other hand, we don't want you to stop saquinavir for the anemia. We want you to know which drug goes with which adverse effect. Now, lamivudine has no major adverse effects. Lamivudine, as a matter of fact, when it was studied, had less adverse effects than placebo. My goodness. Start wanting to get some placebo instead of lamivudine. Now, the big thing about lamivudine is that lamivudine is also effective against hepatitis B. It's effective against hepatitis B as well. So the major issue with antiretrovirals is going to be Can you recognize what adverse effects go with which drugs? Now, a long time ago, this would have been done in a matching question. This would have been done in a question called, please match the following adverse effects with the most likely medications. Please match the medications with the most commonly associated adverse effect. Now, we don't like matching questions anymore, so we do it like real life. A guy goes on 5 drugs, and we want you to know which drugs go with which adverse effects, just like in real life. Patients are not on 5 drugs and they say, hey doc, I think my indinavir has been causing kidney stones. The guy's on 5 drugs and he says, listen, I got flank pain and hematuria. What should I do? Well, you should stop your indinavir, not the didanosine. Because we don't want patients to say, hey, I got kidney stones, I stopped everything. We want them to stop only the medication causing the problem. All protease inhibitors cause hyperlipidemia and hyperglycemia. Only one of them causes kidney stones, indinavir. Only one of them is associated with anemia, AZT. Now, when it's time to start medications, we want people to go on 2 nucleoside reverse transcriptase inhibitors. That's the AZT, didanosine, stavudine group. 2 nucleoside reverse transcriptase inhibitors and 1 protease inhibitor. We want them to go on 2 of these and either 1 protease inhibitor, 2 nucleoside reverse transcriptase inhibitors, and 1 protease inhibitor, 2 nucleoside reverse transcriptase inhibitors, and 1 protease inhibitor, or something called efavirenz, which is a non-nucleoside reverse transcriptase inhibitor. So 1 protease inhibitor or efavirenz. These 2 regimens are essentially pretty close to being equal. Efavirenz has the honor, however, of being the only antiretroviral medication to be contraindicated in pregnancy. It is the only antiretroviral medication, efavirenz, to be contraindicated in pregnancy. Protease inhibitors, hyperlipidemia, hyperglycemia. Only indinavir causes kidney stones. Bactrim with a rash. Dapsone, not in G6PD deficiency. Lamivudine treats hepatitis B, particularly with E antigen positive. So let's look at some specialized things here. And some specialized things would be like this. You have a 30-year-old woman who is on 5 meds for her HIV. She becomes pregnant. What should you do? And the answer is continue what she's on. Everything except efavirenz, you should switch. Efavirenz is the only one that's contraindicated in pregnancy. Woman is HIV positive and becomes pregnant while HIV positive. The answer is continue. Continue. Continue what she's on. If the woman needs medications for herself, don't stop the medications just because she's pregnant. If the woman needs meds for herself, don't stop them just because she's pregnant. Next case, 30-year-old woman who's got a T cell count that's low. Low means in this case less than 350. Or a viral load that is greater than 1,000. T cells that are low, viral load is high. A high viral load in pregnancy means above 1,000. What would you do for the pregnant woman? She is pregnant. What will you do? You will start. You will start. You will start what? You'll start 2 nucleosides and a protease inhibitor. When? Now. Why now? Because she needs the drugs for herself. The baby can't do well if you let the mother die of AIDS. Death of the mother is an adverse pediatric outcome. The worst birth defect is death of the mother. If the woman is on antiretrovirals and becomes pregnant, continue. She needed them for herself. If she comes here and she's got low T cells and a high viral load, and she becomes pregnant, you start the antiretrovirals. If she needs them for herself, you start them now. Now, here's the issue. The bottom line of about when you start antiretrovirals is when the T cell count is low. And when do you start the antiretrovirals? A T cell count that's low, less than 350, or a viral load that's high. Now, the question about the actual cutoff of when to start antiretrovirals is rarely, if ever, asked. Almost never. And the reason is that this is the part of this entire performance that is the most likely to become out of date the fastest. It has changed every 2 years for the last 10 years. So therefore, the boards tend to avoid that question. They tend to not say, a person has 348 T cells, what would you do? A person has 351 T cells, but one of them is suicidal and depressed, what would you do? The boards say, you know what, the person got started on meds, what's the adverse effect? Because when to start is hard. That's difficult, it shifts. When do you start? Low T cells. What is low? Less than 350. What do you start? A combination of 2 nucleosides and a protease inhibitor, 2 nucleosides and ephedrins. If the woman is pregnant, you start the medications now. If the woman was already on medications and she becomes pregnant, you just continue. Now, the only one that's a little bit harder here is this. 30-year-old woman who becomes pregnant but has a T cell count that's high. She doesn't need medications for herself. She wouldn't, if she wasn't pregnant, wouldn't need anything. So what do you do for her? This woman who does not need HIV medications for herself, you give her antiretrovirals just for the 2nd and 3rd trimester to prevent transmission. You give it to her just in the 2nd and 3rd trimester, just to prevent transmission. This is hard for people because they can't understand, well, what's the difference between this one and this one? The difference is this person is going to be sick. They have a T cell count that's low and a viral load that's high. Well, why did I take that viral load of greater than 1,000? That's unique for pregnancy. You see, to start antiretrovirals is actually a viral load here greater than 50,000 to 100,000. Why greater than 1,000 in pregnancy? Because we know that the viral load of 1,000 is the cutoff for when you should be doing a cesarean section. If your viral load is very low and you're pregnant, you don't need a cesarean section. If your viral load is not controlled, you should get a cesarean section. You do a cesarean section if the viral load is not controlled. What do we mean by not controlled? Viral load greater than 1,000. Viral load greater than 1,000 means cesarean section. Because we know that the lower the viral load, the less the transmission. So therefore, cesarean section does not have to be done if the T cells are high and the viral load is low. We know that cesarean section should be offered if the T cells are low or if the viral load is very high. A pregnant woman who does not need meds for herself, high T cell count, who does not need meds for herself, high T cell count, low viral load. This woman gets antiretrovirals just for the 2nd and 3rd trimester. She gets them just for the 2nd and 3rd trimester just to prevent transmission. What happens to these things after she delivers? They stop. Why? Because she didn't need them. She's taking them just to protect the baby. Do you know what the rate of transmission of HIV is from mother to child? The rate of transmission of HIV from mother to child depends on what that T cell count and viral load is. Now, overall, the US figure for transmission from mother to child is somewhere between 25 to 30% with no medications. If you use AZT alone, it's 8%. But with 2 nucleosides and a protease inhibitor and a controlled viral load, it is less than 2%. As a matter of fact, if you get the viral load to undetectable levels and the T cell high, the rate of transmission is less than 1%. Wow. What is it about that uterus and that placenta that protects the baby? The baby is being bathed in maternal blood, but doesn't get the virus transmitted to it. Wow. How protective is that uterus? It kind of makes you want to go out and get one right now, doesn't it? Oh, put the uterus around me. Oh, I feel so warm and comfortable. It's like a studio apartment. Less than 2% transmission. And if the viral load is undetectable, it's less than 1% transmission. It's amazing. You know, Socrates says, the sense of wonder is the beginning of philosophy. Wow. Did you know that you are in the amazing business? Wow. Why do a cesarean section? If your antiretrovirals get the virus under control. Why do a C-section on 100 women to maybe prevent one transmission? Why bother? If the antiretrovirals control the disease, the risk of transmission is under 2%, maybe even 1%. With 2 nucleosides and a protease inhibitor, it's under 2%. If your nucleosides are effective, if you take the little slice of it, of which people are completely controlled, T cells driven up into the hundreds, viral load driven down to undetectable levels, less than 1% transmission. Amazing. Amazing. If the woman needs the drugs for herself, you treat her as if she's not pregnant. If she does not need the drugs for herself, you give her the antiretrovirals during the 2nd and 3rd trimester to prevent the transmission. The relationship between T cells and viral load is like this. We know that a normal T cell count is somewhere up around 600 and 700. We know that pneumocystis and AIDS and evil crap happens around 200 T cells. We know that the T cells drop. Your decrease in T cell count is about 50 to 100 cells per year. That's why it takes somewhere between 5 and 10 years for your T cell count to drop down to a level at which you have AIDS, under 200 T cells. However, we know that some people drop at 100 cells per year, and some people, on the other hand, their T cells drop less. Why is it that some people's T cells will drop at 100 a year, some at 50 a year, and some less than that? What determines the rate of drop of T cells? And the answer is viral load. When you have a very low viral load, your T cells will not drop very fast. When you have a very high viral load, your T cells will drop fast. The T cells tell you what you're at risk of today. The T cells tell you, are you going to get pneumocystis today? Got under 200 T cells today? The viral load tells the future. The viral load says, well, you may have 200 T cells today, but don't worry. Your viral load's very low. Your T cells are probably not going to drop. Or your viral load is very high. Watch out, your T cells are going to drop. So the T cells tell what you're at risk of today. The viral load tells the future. How quickly will they drop? Now, the usual consideration for a high viral load is about 50 and 100,000, except in pregnancy. That cutoff of 1,000 is unique for pregnancy because we have a higher standard in pregnancy. In pregnancy, we want that viral load all the way low because we don't want to transmit it all. Because the lower that viral load is, you prevent death. So therefore, we want that viral load extremely low. Here is our last subject for the new information in this section. And this is that if you have a 25-year-old guy who is a surgical resident who gets stuck on an HIV positive needle, let's say HIV positive needle. He gets stuck on an HIV positive needle. What do you do for this guy? Panic! Ah! No. The answer is post-exposure prophylaxis. 2 nucleosides and a protease inhibitor 2 nucleosides, and efavirenz. 2 nucleosides and a protease inhibitor, 2 nucleosides and efavirenz for 1 month. 2 nucleosides and a protease inhibitor, 2 nucleosides and efavirenz for 1 month. Now, you may notice that I am not being very specific on which nucleosides to use and which protease inhibitor to use. And that's because we don't advertise drug companies here. So, whether or not the person is on lamivudine and AZT, or whether the person is on M-tricytabine, the only difference between these is dosing. Whether or not the person is on AZT or tenofovir only has to do with the fact that tenofovir and M-tricytabine as nucleosides and nucleotides is a once a day. So consequently, these drugs have taken on as the standard of care because they are both once a day medications that can be delivered in one single pill. So it's dosing considerations. Not the exact milligrams. I would not tell you the exact milligrams. But M-tricytabine and tenofovir, together with efavirenz, this plus efavirenz, although efavirenz is in another class, that still constitutes the two, and efavirenz, which also is a once-a-day drug, constitutes the one. And we have 2 nucleosides and a protease inhibitor are non-nucleoside. And these 3 drugs together, one single pill once a day. M-tricytabine, tenofovir, efavirenz. One pill once a day. And that gives us 3 medications. 2 nucleoside reverse transcriptase inhibitor and 1 protease inhibitor or efavirenz. If you get stuck on a needle, 2 nucleosides and a protease inhibitor for a month. If you get splashed in the eyes with HIV-positive blood, 2 nucleosides and a protease inhibitor for a month. What do you do for getting stuck on an HIV unknown needle? The answer is no routine prophylaxis. And then people go, but what if they got stuck on a needle of a person that says that they think they're HIV positive, but they don't know? Well, then you know what, probably. But I can't answer the question because it depends on the circumstances. 2 nucleosides and a protease inhibitor, 2 nucleosides and efavirenz for a month. You get stuck on an HIV-positive needle, a month worth of antiretrovirals. You get splashed in the eyes with HIV-positive blood, a month worth of antiretrovirals. The condom broke with your HIV-positive partner, 2 nucleosides and a protease inhibitor, 2 nucleosides and efavirenz for a month. Can you get HIV from kissing? And the answer is no. You could do all the kissing you want, but that's it. No one has ever gotten HIV through kissing. It's the new romance. All the kissing you want, as long as you don't share needles while you're doing it. And it's okay. Needle stick, a month. Unprotected sexual contact, a month of antiretrovirals. Kissing does not need prophylaxis. Handshakes, hugs, greeting cards, poetry, no prophylaxis required. Now, let's look at some of our imaging here for the HIV section. Now, this is a picture of the virus budding off of a T cell. This is the picture of the virus. Now, in order for this virus to bud off of the T cell, it has to be packaged up in protein. And making this protein package requires a protease. A protease is needed for the protein package. Then it goes and travels along and goes on to the next T cell. But the nucleoside reverse transcriptase inhibitor creates the genetic elements inside of it. The protease creates the package. This is oral thrush, oral candidiasis. Oral thrush and oral candidiasis, although you could do a KOH, the most common way of making this diagnosis is you see white stuff in the back of the mouth, and it is one of the only opportunistic infections that can occur above 200 T cells. So by itself, it is not an AIDS-defining infection. It can occur above 200 T cells. It's one of the only things that can happen with mild forms of immunosuppression. You treat it with oral or topical antifungals, nystatin, clotrimazole, or oral fluconazole. Kaposi's sarcoma. Kaposi's sarcoma is secondary to the organism human herpes virus 8. Human herpes virus 8 does not have a particular antiviral to it. We don't treat it with herpes drugs. Kaposi's sarcoma is treated by fixing the HIV. If you give 2 nucleosides and efavirenz, 2 nucleosides and a protease inhibitor, and raise the T cell count, you will notice that as the T cell count goes back above 200, the Kaposi's will disappear. Herpes zoster is also one of the few infections that can be found above 200 T cells. That's because you don't even have to be HIV to get it. Anytime you have mild lymphocytic suppression, such as just getting older, steroid use, organ transplants, older steroid use or organ transplants, it unlocks the varicella zoster from its reservoir in the dermatomal nerve endings. That's why this is going one stripe and will not cross the midline. One strip of a dermatome but will not cross the midline. Now, this is bilateral interstitial infiltrates. Bilateral interstitial infiltrates. This patient will present with shortness of breath, dry cough, high LDH. Shortness of breath, dry cough, high LDH. Pneumocystis pneumonia, shortness of breath, hypoxia, high LDH from lung destruction, dry cough. If this person presents with this symptoms of dry cough, shortness of breath, hypoxia, and this x-ray, what is the next best step in the management of this patient? Bronchoscopy or starting trimethoprim sulfa? And the answer is start trimethoprim sulfa. What's the indications for steroids? If it is severe. What do we mean by severe? PO2 less than 70 or an AA gradient greater than 35. PO2 less than 70 or an AA gradient greater than 35. If you're allergic to Bactrim for prophylaxis, you get dapsone or atovaquone. But if you're allergic to Bactrim for treatment, it's IV, intravenous pentamidine. Toxoplasmosis happens with more severe forms of immunosuppression. Ring enhancement, this dark stuff is edema. Ring enhancement, this dark stuff is edema. How do you know that this thing here is not a lymphoma? 90% of brain lesions in HIV can be toxo or lymphoma. How do you know? Well, the most accurate thing is to do a brain biopsy. However, treatment for toxoplasmosis and repeating the scan in 2 weeks and looking for a response is sufficiently diagnostic. Treat with pyrimethamine and sulfadiazine and see if these lesions go away. Pyrimethamine, sulfadiazine, and see if the lesions go away. That's your method of confirming the toxo. Treat pyrimethamine, sulfadiazine, and repeat the scan. Now, cytomegalovirus with our little ketchup and egg pattern, here's the ketchup and here's the eggies, a little ketchup and egg pattern, is not something that we talk about a lot anymore because CMV is a very, 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 very unusual disorder. 10 years ago, it used to be someone with CMV in the hospital all the time. Now, many infectious disease fellows will be trained and never see a single case. CMV, cytomegalovirus retinitis, is going to be less than T cells, less than 50 T cells, and blurry vision. And when left to T cells and 50 T cells and blurry vision, you're going to do a dilated ophthalmologic exam and give either ganciclovir or foscarnet. What is the most common adverse effect of ganciclovir? Ganciclovir is suppressive on the marrow and causes you to have a low white blood cell count. What's the most common adverse effect of foscarnet? Now, I would be stunned if you knew the answer to that, except you're looking at the book in front of you. Foscarnet is renal toxic. Foscarnet is renal toxic. So, blurry vision and less than 50 T cells, dilated exam, you see this abnormality, you give ganciclovir and foscarnet, and we're done. If you give antiretrovirals and the T cells go up, can you stop the antiretrovirals? And the answer is no. If you give the antiretrovirals and the T cell count goes up, you can't stop the antiretrovirals because as soon as you stop them, the T cells will go back down. If you give antiretrovirals and the T cells go up, can you stop the ganciclovir and the foscarnet? And the answer is yes, because If you have high T cells, it will get rid of the CMV and the pneumocystis, and it won't recur. And it won't recur as long as the T cells stay up. Now, the last thing for our HIV section is this. It's called immune reconstitution. And immune reconstitution is a kind of one of those having to pay taxes on the $1 million you won in the lottery problems. The good news about antiretrovirals is that if you're fortunate enough to live in one of the parts of the world that has access to these medications, the death rate from HIV is down by 90%. Because it's very hard to die of HIV if you have access to antiretrovirals. On the other hand, you ready? 35-year-old guy starts 5 antiretrovirals, 2 nucleosides and a protease inhibitor, Bactrim, azithromycin. He starts the medications, the highly active antiretroviral therapy. And 4 weeks later, he develops himself a headache and is found on a CT scan to have ring-enhancing lesions. How did this happen? That's called immune reconstitution. He develops pneumocystis after starting antiretrovirals, immune reconstitution. He develops cryptococcal meningitis after starting antiretrovirals, immune reconstitution. Ready? Here's an unknown, mysterious problem. Why is it that when the immune system is being reconstituted, that certain opportunistic infections express themselves? We don't know. We do know that there are probably little bits of the information or those organisms stuck within the immune system. And when the immune system becomes strong again, for some reason, those opportunistic infections become expressed. It can result in fevers, it could result in toxo, CMV, cryptococcus, pneumocystis. We don't know why. But as the immune system is reconstituting itself, you get an opportunistic infection. So the management of this is treat the opportunistic infection, and eventually, as the antiretrovirals raise the T cell count, the opportunistic infection will go away. But it happens to be this. It's a paradoxical, unknown, mysterious, adverse problem of why it is that as your immune system is getting stronger, you express an opportunistic infection. Why? Unknown. If you try and think about it too much and you can't remember it because you can't understand it, well, you're just going to have to accept it. It's just the way it is. It happens. We don't know why. We just know that as the immune system reconstitutes itself, people can have opportunistic infections disseminated. What do you do differently? Nothing. There's nothing you do. Treat the opportunistic infection. All significant post-exposure prophylaxis, needle sticks, sexual contacts, splashed in the eyes with HIV-positive blood. Get 2 nucleosides and a protease inhibitor, 2 nucleosides and efavirenz for a month. You don't have to prophylax urine or stool exposures or kissing because it doesn't contain white cells. And unless it says stuck on an HIV-positive needle, don't prophylax routine needle stick injuries because the risk of transmission is too small. HIV has undergone a more rapid development of medications than any other disease in the history of the world. Between 1782 to 1950, there was one drug for congestive failure, digoxin. Between 1950 and the year 2007, we added beta blockers, ACE inhibitors, angiotensin receptor blockers, spironolactone. In the next 50 and 60 years. 1981 was the first description of HIV. Between 1981 and its approval in 1987, there was one single antiretroviral, AZT. Between 1987 and 2007, there are now 20 separate antiretrovirals in 5 classes that have been approved in a 20-year period. We live in an age in the world where we're able to do more for everybody, take care of people more than ever in the history of the world, relieve more suffering, cure more disease. Things that were formerly all fatal, now, what do? 3 medications in one single tablet once a day.